Welcome to Prison BBV Champions Training. What I wanted to take you through first are the reasons why I believe this matters and why you should sit and listen to this training. Okay. First of all, let's think about bloodborne viruses and the impact that they have on the world. So currently, according to the World Health Organization, 350,000 people every year are dying of hepatitis C. And hepatitis C is a disease that we can cure with tablets. Hepatitis B, more than twice that number are dying every year, and we have a vaccine that can block people from becoming infected. Viral hepatitis causes the liver to scar, and that severe scarring is something that we call cirrhosis. That's when your liver will start to stop working. We tend to think of liver disease as being associated with alcohol, but if we look globally, more than half of all liver cirrhosis is due to hepatitis B and hepatitis C. And 78% of all liver cancer globally is due to viral hepatitis, to bloodborne infections. And thinking even more broadly than that, 2.7% of all deaths around the world are due to these viruses. This is a really big deal. But that's globally. You might feel that you're more concerned about what happens in the UK. So this is data looking at mortality and morbidity, death rates associated with a range of different diseases. You can see here we've got liver disease, we've got things like diabetes, cancer, respiratory disease, road accidents, heart disease, stroke. These things are in the news all the time. And we're always alarmed as to how big a problem we have with these things. And I'm not dismissing them. I just wanted to highlight what's happening. So since 1971, the rates of all of these, except one, has gone down. So as a healthcare system, we're doing a great job. We're reducing the risk of death with diabetes, of cancer, heart disease, stroke, even road accidents. The one that's steepling upwards is liver disease. In the UK, we have a significant public health issue with liver disease. So what this graph is showing us is retrospectively the numbers of people whose livers are failing, and looking at what might happen prospectively. So the grey bars represent the numbers of people with liver failure, and the orange bars are the numbers of people with liver cancer. And retrospectively, we can see that over time, the numbers of people with these end-stage complications is going up and up and up. That's a massive increase in clinical burden, and it's also a significant financial burden with the potential to overwhelm the healthcare system. What I find alarming is that this data was finished being collected around about 2011. We've now got the data back for 2015 and it's remarkably accurate. So unless we do something, we will end up with predictions going up as we go forwards. So clearly a public health issue. Now, at medical school, learning about public health, I remember a lot of discussion about rivers. There were lots of mentions of upstream factors and downstream factors. So when I was thinking about hepatitis C, sort of natural for me to use a river as an analogy. So if you can imagine, this is a disease that to a certain extent has a flow to it. We become infected, and in the UK, 90% of people become infected because they inject drugs. You become infected and you enter this flow. You enter at the top there, high up in the mountains. And as your disease progresses, your liver slowly, over time, becomes more and more fibrosed until you get those end-stage complications, things like hepatocellular carcinoma, liver failure leading to transplant. This analogy actually works remarkably well because the river gets wider and wider, and you might imagine that the width of the river gives you some idea about the clinical challenge of managing these patients, and also the financial burden that they that they have on the health service. So not surprisingly, our strategy to date has been to, if you like, place our clinicians somewhere in the lower reaches of this river, with the aim of trying to fish people out as they go past, so that they don't end up causing these end-stage complications. Now, one of the first questions I ever asked as a virologist, I asked my PhD supervisor, why don't we treat the people who inject the drugs? Why don't we stop people getting infected right at the start? And what he said was, don't be ridiculous, Kevin. These people, they don't turn up to the clinic. You can't treat them. They won't finish their treatment. It's a waste of money. If we could do that, then clearly the river would dry up. That's essentially what I'd like to achieve. But if you're stood on this bridge and you look up into the mountains, if you look up into the places where the homeless guys hang out, where drug use is rife, they seem very distant and dangerous places that you don't necessarily want to go to when you're sat in your nice comfortable clinic. But actually, if you were stood up in those mountains and you look and try and find hospital services, they can also seem pretty distant and forbidding places. So if we want to address somebody who's injecting drugs, if we want to target that audience, we need to think about who these people are. So what I did was to amalgamate a number of stories that I've been told about this population. So James isn't a real name, and this isn't a picture of somebody called James necessarily. But this case history rings true. Most people who listen to this turn around to me and say, I recognise James. So let me tell you about James. James is of no fixed abode. He's homeless. He's kicked out of his house when he was 18, when he stopped pulling in benefits for the household. He's now 23 years old. He's addicted to heroin, and his route of administration is injection. His health status, well, he's got hepatitis C, but he doesn't know he's got hepatitis C. What he does know is he's broken his right scaphoid. Now, talking to him, it would appear that he broke his hand when he fell off that bridge, the wall, you know, the one by the bridge. But actually he's not quite sure, because he did fall out the second-story window a couple of months ago. Now, if I break my hand, my response is to go to A&E and get it fixed. That's because I have a health-centric paradigm. James does not have a health-centric paradigm. James's hand hurts, but he knows his friend John can provide pain relief. So he straps his hand to himself and he wanders off, and he gets pain relief from his friend John, who got paid today. James's mindset revolves around graft, score, hit. So the language changes depending on where you are in the country, but graft means to steal. Score means to buy drugs. Hit means to take drugs. So we want to address hepatitis C with James, but actually he's not listening. He's not listening because he's got so many priorities that sit above that. So right now, James's principal concern is that his hand really hurts and he'd quite like some pain relief. It's raining. He's cold. He's wet. He's hungry. If you want to talk to James about healthcare, he's interested in the psychiatric support for the problems that he has with his dad. Quite like some addiction intervention. He's not happy with his addiction. Somewhere a long way down this list is a virus called hepatitis C that might kill him at some point in the future. Now the thing about James is he's not very good at the graft bit. In fact, Jameses in general aren't very good at the graft bit. Surveying people who inject drugs, we found that 71% had spent at least some time in prison. So James gets involved in a street mugging. James ends up going to prison. Now in prison, he's got access to pain relief. He's got a roof over his head. He's got food, he's got water, he's warm. He's actually got mental health services. He's got addiction intervention. Now, sat in prison, James might listen to us about bloodborne viruses. Now is an opportunity, an island of stability that allows us to talk to James about bloodborne viruses. So let's stop and think about what impact that would have if we could do that. So this is the last piece of data for a bit. This is Scottish data. So if you want to think about it in English terms, you probably need to add a 0 onto the end of all of the numbers, because there are 10 times as many English people as there are Scottish people. So what this looks at, it asks the question, what would happen to the numbers of people with liver failure and the numbers of people with hepatitis C if we were to just double the number of people we treated and treat them with the newer DAAs? Okay? So, first of all, let's think about the blue line. If we increase the treatment numbers, the numbers of people with liver failure will begin to decline because we'd start to have an impact. We would stop this epidemic rising and we would start to reduce it. Also, that we wouldn't have quite so much of an impact on the prevalence. The next question that this data addresses is what happens if we start to be selective about who we treat. So the blue line represents what would happen if we just continue to treat exactly the same patients as we treated before. The green line represents that focus on the patients who are sickest. Not surprisingly, if you want to have the quickest impact on preventing liver failure, then treating the people who are about to have liver failure, the people who are at the bottom reaches of that river, has the most impact here, has a modest impact. If, however, you want to change the prevalence of hepatitis C, if you want to stem the flow, what we clearly need to do is to follow the red line. And the red line are the Jameses of this world. We need to find a way of focusing on the Jameses, because that's what I want to achieve. I want to be able to walk away from my career and tell people that hepatitis C isn't really something we need to worry about anymore.